Which structure arises from the abnormal detachment of primitive foregut and are most often located in the hilum or middle mediastinum? The answer is foregut cysts arise from abnormal detachment of primitive foregut and are most often located in the hilum or middle mediastinum. Depending on the wall structure, these cysts are classified as bronchogenic cyst, esophageal, or enteric cyst. A bronchogenic cyst is rarely connected to the tracheobronchial tree. Most common site of foregut cyst is middle mediastinum. Foregut cysts arise from the abnormal detachment of primitive foregut and are most often located in the hilum or middle mediastinum. So most common type is bronchogenic cyst. Suprapulmonary sulcus carcinoma, Pankos tumors are bronchogenic carcinoma that typically produce which of the following clinical features? Pankos tumors are peripheral bronchogenic carcinoma that produce symptoms by involvement of extrapulmonary structure adjacent to the cupula. These structures include the nerve roots of C8 and T1 as well as the sympathetic trunk. Interruptions of the cervical sympathetic trunk leads to meiosis, ptosis, and hydrosis, the triad of signs that constitute Werner syndrome. Involvement of the nerve roots causes pain along the corresponding dermatomes. The peripheral locations of the neoplasm makes pulmonary signs such as atelectasis, cough, and hemoptysis unlikely. Surgery is indicated in the initial management of lung cancer in the presence of which of the following? Hypercalcemia is attributed to the secretions of parathyroid hormone from a localized squamous cell carcinoma. Paraneoplastic effect. As such, involvement may be seen after surgical resection. Following extension of the tumor into the chest wall, radiotherapy and subsequent extensive resection carried out in selected cases may occasionally be indicated. Small cell carcinoma, also known as Oat cell carcinoma, accounts for 20 to 25% of cases of bronchogenic carcinoma, arise centrally and tends to metastasize widely. The initial treatment is combination chemotherapy followed by radiotherapy in those whose cancer responds. The next question is the most common primary tumors of the anterior mediastinum is thymoma. Thymoma are the most common primary tumors of the anterior mediastinum. Neurogenic tumors are the most common primary tumors of the posterior mediastinum. Then schwannoma and the neurilemoma are the most common neurogenic tumor, which occurs mostly in the posterior mediastinum. Then thymoma is the most common anterior mediastinum. Pericardial cysts and bronchogenic cysts are seen in the middle mediastinum. Drugs used in chemotherapy for lung cancer. Chemotherapy for non-small cell cancer, lung cancer includes cisplatin, carboplatin, paclitaxel, docetaxel, gemcitabine, irinotecan, etoposide, vinblastine. Chemotherapy for small cell lung cancer. Then are cisplatin, etoposide, carboplatin, and etoposide, cisplatin and irinotecan, carboplatin and irinotecan. A previously healthy 20-year-old man is admitted to a hospital with acute onset of left-sided chest pain. The electrocardiographic findings are normal, but chest X-ray shows 40% left pneumothorax. Treatment of choice of which of the following procedure? Spontaneous pneumothorax usually results from the ruptures of subpleural bleb in the young man, age 20 to 40, which is often signaled by a sudden onset of chest and shoulder pain. Pneumothorax of more than 25% requires placement of a chest tube. Thoracotomy with bleb excision and pleural ablation is generally recommended if spontaneous pneumothorax is recurrent. Small pneumothorax in patients with minimal symptoms usually resolve and therefore can be observed as spontaneous perforation of the esophagus. Bohab syndrome can result in hydropneumothorax as well as more usual pneumomediastinum, but would not present with an isolated 40% pneumothorax. Barium cello is appropriate diagnostic test for evaluation of suspected leaking esophagus. So, a previously healthy 20-year-old man is admitted to hospital with acute onset chest pain. The echocardiographic findings are normal, but chest X-ray shows 40% pneumothorax. So, treatment of choice is tube thoracostomy. Because in pneumothorax of more than 25% requires placement of chest tube. Thoracotomy with bleb excision, pleural ablation is generally recommended if spontaneous pneumothorax is recurrent. Small pneumothorax can resolve and therefore can be observed. The next question is Rosmussen's aneurysm is seen in the aneurysm of the pulmonary artery within pulmonary cavities called Rosmussen's aneurysm, which can result in massive bleeding. Most cases of massive hemoptysis arise from the bronchial arterial tree. Even with a pulmonary aneurysm is present, the actual bronchial bleeding may be from bronchial artery rather than from the pulmonary artery. Which of the following is true concerning aortocoronary bypass grafting? So options are, it is not indicated for chronic disabling angina. It is associated with a 10% operative mortality. It is indicated for crescendo angina and is indicated for congestive heart failure. So coronary artery bypass surgery was developed in the late 1960s and is now being regularly performed. Indication for surgery include chronic disabling angina, crescendo angina. Cardiac catheterizations with selective coronary angiography defines the extent of disease, which generally is localized to proximal segments of the vessel. Operative mortality is about 2% and relief of angina is obtained in most affected patients. Patients with left main coronary artery disease as well as those with triple vessel disease have ventricular dysfunction. Having increased longevity following successful bypass. Data regarding extensions of life in other group is conflicting. Coronary artery bypass is not indicated for congestive heart failure unless this condition is ischemic in origin and angiography identifies disease amenable to surgical revascularization. So the indications of surgery include chronic disabling angina and crescendo angina. Next question is failure of adequate drainage in an empyema with bronchopleural fistula is indicated by failure of adequate drainage in an empyema with bronchopleural fistula is indicated by continued protective cuff with purulent material, drainage less than 100 cc, hemorrhagic drainage less than 100 cc per day, the development of hemoptysis. These clinical signs of getting bronchopleural fistula is outlined as continued protective cuff with purulent material, especially when the patient is rolled on the other side of side having fistula. So ECG is most consistent with myocardial contusion that result from accident. The incidence of myocardial contusion is about 25% in patients with severe blunt injury to the chest. The injury occurs as a result of direct compressions of the heart between the sternum and the vertebral column. The right ventricle, being the most anterior portion of the heart, is most commonly injured portion. The below causes extravasations of blood into the myocardium, resulting in a progressive loss of ventricular compliance and decreased cardiac output, which usually peaks by 8 to 24 hours after the injury. Several days following esophageectomy, a patient complains of dyspnea and chest tightness. A large pleural effusion is noted on the chest radiograph, and thoracosynthesis yields milky fluid consistency with time. Management of lung abscess refractory to prolonged antibiotic treatment includes all of the following. Patients who do not respond to initial regimen and who do not have surgical indication, early percutaneous drainage is done. When surgery is indicated, lobectomy is a preferred choice. Tube thoracotomy and open pleural drainage is also done for lung abscess. So, management of the lung abscess refractory to prolonged antibiotic treatment includes all of the following except. So, open drainage and lung abscess, we can do open drainage, lobectomy, tube drainage, but intracavitary antibiotic installation is not done. The superior vena cava syndrome is most frequently seen in association with superior vena cava obstruction is almost always due to malignant, and in 3 out of 4 cases results from infections of the vena cava by bronchogenic carcinoma. Lymphomas accounts for most of the remaining cases of the superior vena cava syndrome. Fibrosing meningitis as the complications of histoplasmosis or a correct statement concerning bronchial carcinoma tumors is that options are the most commonly arise in the peripheral terminal bronchioles. They are radiosensitive, they frequently metastasize, they rarely produce a carcinoid syndrome. So bronchial carcinoid tumors rarely produce a carcinoid syndrome. They are slow-growing, infrequently metastatic tumors that histologically resembles the carcinoid tumors of the small intestine. Over 80% arise in a major proximal bronchi, and the intraluminal growth is responsible for the frequent presentations of bronchial obstruction. The only therapy for this lesion is operative resection, because neither the primary tumor nor the infrequent lymph node metastasis is radiosensitive. The low malignant potential for this lesion is reflected by a long-term survival rate that approaches 90%. In evaluating the chest X-ray finding in a 60-year-old man with pleural effusion, which of the following constitutes an abnormal finding of the pleural cavity? Options are communication between the right and the left pleural cavities, existence of different attachments of the right and left side, existence of both parietal and the visceral layer in the upper part, intersection of the 12th rib posteriorly. On left side, the pleural reflection deviates to the left, anteriorly between the 4th and the 5th costal cartilage. to accommodate the cardiac nodes. Although the right and the left pleural reflection approach each other in the midline, and there is no direct communication between the two sides. So, which of the following constitutes an abnormal finding? That is communication between the right and the left pleural cavities. Lymphoma most commonly affects which compartment of the mediastinum? Lymphoma most commonly affects anterior mediastinum is the most common site for lymphoma. Occasional involvement of the middle compartment and rare involvement of the posterior compartment. Chemotherapy and or radiotherapy results in a cure rate of up to 90% for early stage Hodgkin disease and up to 60% for more advanced stages. Most common tumors of middle mediastinum is lymphoma, and most common mass of middle mediastinum is pericardial cyst. So lymphoma most commonly affect anterior compartment, anterior mediastinum. A non-cyanotic 2-year-old child has a systolic murmur along the left sternal nodes, sternal border. The examination is otherwise normal. Chest X-ray and echocardiographies are normal. This finding is most commonly associated with which of the following congenital heart disease? So ventricular septal defect accounts for 20 to 30% of all congenital cardiac anomalies. It may lead to cardiac failure, pulmonary hypertension, if the defect is larger than 1 centimeter, or it may be asymptomatic if the defect is small. Surgery is not indicated for asymptomatic patients with a small defect, since the substantial numbers of these anomalies flow spontaneously during the first year of life. Operation is indicated in infants with congestive heart failure or rising pulmonary vascular resistance owing to the left to right shunt. When symptoms are mild, can be controlled medically. Operation is usually delayed until age 4 to 6 years. Operative mortality ranges from less than 5% to more than 20% depending on the degree of pulmonary vascular resistance. Tetralogy of Fallot, transposition, and tricuspid atresia are cyanotic lesion. Congenital cyanosis that passes beyond the age of 2 years is associated, in the vast majority of cases, with the tetralogy of Fallot. Patent ductus arteriosus is associated with characteristic continuous machinery murmur. The following are indications for performing thoracotomy after blunt injury to the chest, except indication for thoracotomy, except. Examples, the options are fracture, continuous bleeding through intercostal tube of more than 200 ml per hour for 3 or more hours. Cardiac tamponade, more than 1500 ml drainage after placing an intercostal tube. The fracture is not an indication for thoracotomy. Indication for thoracotomies are initial tube thoracoscopy, drainage of more than 1000 ml or more than 1500 ml. For penetrating injury for more than 1000 ml, and for blunt injury more than 1500 ml. Ongoing tube thoracostomy, drainage of more than 200 ml per hour for 3 consecutive hours in non-coagulopathic patient. Then get hemothorax despite placement of 2 chest tube. Then tracheobronchial injury, selected descending torn aorta or great vessels injury, pericardial tamponade, cardiac herniation, massive air leak from a chest tube with inadequate ventilation, open pneumothorax and esophageal perforation. A 36-year-old man is crossing a bridge when he is suddenly swept by a torrent into the river. After rescue and resuscitation, he is admitted to the ICU of the local hospital with ARDS. Which of the following features are suggested diagnosis of ARDS? Example: the options are high lung collapse, interstitial edema with normal pulmonary capillary wedge pressure, activations of surfactant, then consolidation confined to the lingula. In ARDS, poor alveolar gas exchange and interstitial edema are evident in the presence of normal or lowered pulmonary capillary wedge pressure. In ARDS, poor alveolar gas exchange and interstitial edema are evident in the presence of normal or lowered pulmonary capillary wedge pressure. The changes are caused by damage to the capillary and alveolar epithelial cells, consequent to the release of pro-inflammatory cytokines, which in turn arise from stimulated lymphocytes and macrophages. Other clinical features suggestive of ARDS are diffuse diffuse pulmonary infiltrates, and refractory hypoxemia. So the correct option is interstitial edema with normal normal pulmonary capillary wedge pressure. So which of the following is false about hemoptysis? In an unstable patient, rigid bronchoscopy is done to identify the lesion. CT is the first investigation done. In 90% cases, bleeding from the bronchial arteries. Massive hemoptysis is bleeding more than 600 ml in 24 hours. So hemoptysis source of bleeding is bleeding from the bronchial arteries. Then up to 20% of patients with lung cancer have hemoptysis sometimes. Endobronchial metastasis from carcinoma tumor, breast cancer, colon cancer, kidney cancer, melanoma may also cause hemoptysis. Massive hemoptysis is defined as more than 600 ml of blood produced in 24 hours. So the fourth option is correct. Then third option is correct. When refractory difficulty occurs, hemoptysis should be treated emergently. The first priorities are to maintain the airway, optimize oxygenation, and stabilize the hemodynamic status. CT is not the first investigation of choice. Chest X-ray is the first investigation of choice. If the bleeding side is known, the patient should be placed in a lateral decubitus position with the bleeding side down to prevent aspiration into the unaffected lung and give supplemental oxygen. If large volume bleeding continues or the airway is compromised, the patient should be intubated and undergo emergency bronchoscopy. As most large volume hemoptysis arise from an airway lesion, it is ideal if the site of the bleeding can be identified, either by chest imaging or bronchoscopy, more commonly rigid than flexible. As most large volume hemoptysis arise from an airway lesion, it is ideal if the site of the bleeding can be identified, either by chest imaging or bronchoscopy. So if the site of the bleeding is detected, either the patient undergoes a definitive surgical procedure or the lesion is treated with neodymium, NDA laser, or argon plasma coagulations or electrocautery. So the CT is not the first investigation to be done. Next question. A young man with pulmonary tuberculosis presents with massive recurrent hemoptysis. With angiographic treatment, which vascular structure should be evaluated first? So the answer is bronchial artery, because bronchial artery is a major source of hemoptysis. Blood supply to the interlobar sequestration is from thoracic aorta. Pulmonary sequestration is an area of embryogenic lung tissue separate from the lung, which receives blood supply from an anomalous systemic artery from the aorta. Extralobar sequestration occurs primarily on the left side, and blood supply is usually from the thoracic or upper abdominal aorta. Intralobar sequestration occurs in the lower lobes, predominantly more than 95%, and is equally distributed between the right and left lower lobe. So blood supply is from descending thoracic aorta, and supply is from pulmonary veins. So excisional biopsy of a chest wall mass is allowed if excisional biopsy of a chest wall mass is allowed if imaging reveals classical appearance of chondrosarcoma less than 2 cm. Needle biopsy was non-diagnostic. It is more than 3 cm. None of the above. Needle biopsy pathologists experienced with sarcoma can accurately diagnose approximately 90% of the patients using FNS cytology. A needle biopsy has the advantage of avoiding wound and body cavity contamination. If a needle biopsy is non-diagnostic, an incisional biopsy may be performed with caveats. First, the skin incision must be placed directly over the mass the skin incision must be placed directly over the mass and oriented to allow subsequent scar excision. Skin flaps and drains must be avoided. However, if the surgeon believes a hematoma is likely to develop, a drain is useful for limiting soft tissue contamination by tumor cells. At the time of definitive surgical resection, the en bloc resection includes the biopsy scar and the drain tract along the tumor. So excisional biopsy, any lesion less than 2 cm can be excised as long as the resulting wound is small enough to close. So needle biopsy. The needle biopsy was non-diagnostic is false, and excisional biopsy can be done if it is less than 2 cm. The primary site for male patients with malignant pleural effusion is lung. The malignant pleural effusion may occurs in association with a number of different malignancies. Most commonly, lung cancer, breast cancer, lymphoma, depending on the patient age and gender. So, the primary site for male patient with malignant pleural effusion is lung. A student with human known HIV infection has lost 6 lb in weight, and his sedimentation rate is increased to 40. He has no other symptoms. The Monto test result shows a change of 7 mm. Tuberculin test is positive, and X-ray finding gives a small lesion in the apex of the right lobe of the lung. How should this patient be managed? Option 1 is hospitalized in a public ward, treated as an outpatient with triple anti-tubercular drug therapy for 2 weeks. Treated as an outpatient with multiple anti-tubercular drug therapy for 2 months, and then appropriate anti-tubercular drug for 4 months. Hospitalized in an isolated hospital room. So the option is treated as an outpatient with multiple anti-tubercular drug therapy for 2 months, and then appropriate anti-tubercular drug for 4 months. So in an early stage of HIV, infection, skin testing for tuberculin is intact. However, false positive result occurs because of the infection by non-tuberculous myocardium and are common because of the immune disorder. Most patients with tuberculosis who are compliant can be treated on an outpatient basis. So, treated as an outpatient with multiple anti-tubercular drug therapy for 2 months, and then appropriate anti-tubercular drug for 4 months. Most common abnormality associated with hypoxemia, hypercapnia, bilateral alveolar infiltration, and all. So, a large-scale randomized control trial sponsored by the National Institutes of Health and conducted by the ARDS. Mortality was significantly lower in the low VT patients when compared to conventional VT patients. So, the improvement in survival represents the most subsequent benefits in ARDS mortality demonstrated for many therapeutic interventions of ARDS to date. So, the most common abnormality associated with hypoxemia. The chest X-ray of a 62-year-old woman who complains of weakness, dyspnea, and hemoptysis shows multiple nodules in the right lung. She says that dyspnea is worse in a supine position and improves on sitting up. On examination, the physician notes multiple hemorrhagic telangiectasia in the mouth and in the skin of the upper chest wall. There is a mild increase in the erythrocyte count, and partial pressure of oxygen is 90. An angiogram shows multiple pulmonary AV fistula in both lungs. What should be the next step in treatment? So the presence of multiple masses on a chest X-ray should alert the physician to the possible diagnosis of pulmonary AV fistula. Needle biopsy and endotracheal biopsy of the lesion should not be attempted because severe hemorrhage may be precipitated. Paradoxical emboli, brain abscess, and hemothorax are recognized complications if the fistula is localized. Resection is undertaken. In multiple lesion, therapeutic embolization is done. In addition to AV formation, multiple masses on a chest X-ray would be due to metastasis, granulomatous infection, sarcoid, or rheumatoid arthritis. So the answer is therapeutic embolization. A stockbroker in his mid-40s consult you with complaints of episodes of an incapacitating chest pain on swallowing. The diagnostic studies on the esophagus you have ordered yield the following: this endoscopic examination and biopsy mild inflammatory dystally. So, the diagnostic studies listed reveals minimal reflex esophagitis, normal lower esophageal sphincter relaxation and pressure, and an incidental small epiphrenic diverticula. None of these findings justifies treatment, and none explains the patient's symptoms. On the other hand, the finding of prolonged high-amplitude contraction in the body of the esophagus in a highly symptomatic patient is diagnostic of diffuse esophageal spasm. The cause of this hypermotility disorder is unknown, but its symptom can be disabling. The recommended treatment for this relatively rare disorder is a long myotomy guided by the manometric evidence. If the lower esophageal sphincter is functioning properly, most surgeons would now recommend stopping the myotomy short of the normal lower sphincter. It should continue upwards at least at a level of the aortic arch higher if manometric findings of the spasms are noted above the level. 80 to 90% of the patients treated in these patients will experience acceptable relief of symptoms. So the answer is myotomy from the level of aortic arch to distal sphincter. No disruptions of lower esophageal sphincter. So the diagnosis is reflux esophagitis. For that we do myotomy from the level of the aortic arch to the distal sphincter. No disruptions of lower esophageal sphincter. Most common cause of amoebic lung abscess is by inhalation, lymphatic spread, direct extension from liver, or hematogenous spread. So amoebic lung abscess is a result of direct spread of infection from the liver to lung. Infection spread directly through the diaphragm. So most common area of lung involved is right lower lobe. 28-year-old bank employee undergoes investigation for infertility that revealed oligospermia. On further inquiry, it is found that he has suffered from repeated bouts of coughing since childhood and episodes of recurrent pancreatitis. Clubbing of the finger is evident, which test is most likely to reveal the cause of chronic lung disease. Cystic fibrosis is the most common cause of chronic obstructive lung disease in children and adolescents. So it is an autosomal recessive disease that affects widespread exocrine glands. Cold is evident in all patients who survive childhood. So the test most likely to reveal is sweat chloride elevated to over 80 milliequivalent per liter. For an adenocarcinoma that has pleural invasion, tumor necrosis, and has lymphovascular invasion, the correct subtype is lipidic predominant adenocarcinoma. If lymphovascular invasion, pleural invasion, tumor necrosis, or more than 5 mm of invasion are noted in a lesion that has lipidic growth as its predominant component, minimally invasive adenocarcinoma is excluded. The lesion is called lipidic predominant adenocarcinoma. The size of the invasion component is recorded for the T-stage. In the evaluation of a 64-year-old woman with fluctuating neurological signs of ptosis, 11th and 12th cranial nerve palsy, and generalized extremity weakness are noted, and eudophonium given intravenously, resulting in clinical improvement. On computer and CT scan shows a lesion in the antiomedicinum, and a biopsy confirms the presence of thymoma. She should undergo which of the following? The role of thymectomy in treating patients with myasthenia gravis who have a thymoma is well established. The thymus gland is located in the antiomedicinum and can be approached by cervical or medicinal approach. It arises from the third and fourth bronchial arches. Thymectomy is frequently advised for patients with myasthenia gravis who do not have a thymoma. However, there are some authorities who would treat this patient initially with an anticholinergic drugs such as pyridostigmine. Corticosteroid therapy may be indicated when thymectomy has failed, but it must be undertaken cautiously because of the lung may precipitate severe weakness. Pneumococcal infection, which may occur after splenectomy performed in children, are not a specific complication of that after thymectomy.